have the incoming president, Dr. Partha, who's going to speak now. My experience with new generation presbyopic correcting IOLs, 8 minutes for you, sir. And he has got to go to another session, that's why there's reschedule. Thank you, sir.
For this, and thank you very much for giving me a change in the order. Now, whenever we are approached for a new type of IOL, this is the best, this is better than the rest, and everything else. The important fact that we have to think back is, am I going to change? Is there a need for a change? And is it better for my patient for a change? And that is the time when we need to evaluate, or we need to see what the literature says, even the literature that goes on with the lens or any other particular device that is used. So it is for any new trifocal lens coming into the market, which professes that things are better for the patient. Because let us remember, our demands of the patient is very high. The correction of presbyopic IOLs are going from one aspect to the other, one level to the other, and the demands and the requirements of patients' lifestyle is indeed changing. So there is a need, because we need to evolve, we need to become better. And spectacle independence is what everyone is looking for at a cataract, after a cataract surgery. So we have this whole spectrum of IOLs, the routine IOLs and the premium IOLs. We should not be calling them premium IOLs, but advanced IOLs maybe is a better name for it. And when we talk about the advanced IOLs, the advanced designed IOLs, then it is important to remember that the torics, the EDOFs and the trifocal IOLs are giving a big advantage to our patients. Now let us look at this new intraocular lens that has just come into the Indian market just about 10 days ago. And before I implanted this IOL, and they said that you're going to be the first one to implant this IOL, sir, you sneezed at that. Yes, I also nearly sneezed. I would have loved to have other people have implanted at least 3 months down the line. What does it look? What do your patients say? Is it better? Do they have glare, etc., etc.? But they said that do implant because, and then I implanted. Why this first time is because they have a preloaded platform, which is definitely an advantage, and the incision size is 2.2, and that is something that's important. Trifocal diffractive and the near ad as well as the intermediate ads are in good position, hydrophobic, and we trusted this heparin coated CT Lucia platform for ages, and it is a good design. Now, when we looked at the design is like the CT Lucia, and the PCO rates definitely are very, very low comparable to any of the modern IOLs. So the Ilana that has really come in, it has the focal planes at 40 centimeters and 80 centimeters, things that we want. And then when we came to looking at the light distribution, so the light distribution for the far, near, and intermediate, in fact, for the near, it is a little more, 35%, I think, it is, than the other intraocular lenses, the other trifocal intraocular lenses, which are just about 25. So with the Ilana, this becomes an advantage if a patient is desirous of a reading vision improvement and focus towards the reading vision. They said that it is the SMP technology. So what is SMP? I wanted to know. And the SMP is that it has a smoothness profile which creates a very ideal surface of the design, and for that can be manufactured very precisely, and the uncontrolled scatter of light is minimized. I would not say it's not there, but it is minimized. So also the other benefits come in. It is glistening free material, which is a very important aspect, the limit of positive dysphotopsia, the square edge design, and the C-loop design, which we were actually used to with all the trifocal lenses. So the delivery system is something that we have been using. Of course, if you have used the CT Lucia, it's a little stiff. It goes in a little stiffly, but it definitely can go in with a hydro implantation. You don't need to put viscoelastic. It goes in very well. You just have to position your cartridge extremely well and not lose grip of the contact between the tissue and the cartridge. So this was our patient, 56-year-old lady. She's an executive. She said that I want to go to Switzerland in 15 days' time. Can you do both my eyes, and can I go to Switzerland? And I want to see the Alps, and I love to read, so I would love to stay in my hotel room, see the Alps, and read without glasses. So a very high expectation from this patient. We told her that these are the things that we have looked into, and this is the IOL of choice that we are going to do. And she underwent the intraocular lens. So it's quite simple. I mean, the other thing that is important is you can actually load this cartridge by yourself. You don't need to give it to your assistants to load it, and the visco is to be there. And it's very easy to implant. It's not a difficult cartridge, and the ease of implant is also very important in all these lenses. They should go in smoothly without any roughening of either the optic or the haptic structure, which at times can happen with the preloaded aspects. So this we are implanting it under hydration, and you just have to place it in. It goes in, and you can just tweak in and place it in very well and position it. So this is just the simplicity of the hydration and the placing in of the lens. And she's doing well, and she has put in a text from Switzerland saying that she's feeling very nice. So that's a big take for us. But let us remember that just one patient does not give you the full pudding. You have to have it tasted by multiple. So the more the people use, let us collaborate the practical aspects of the happiness of the patient, because that ultimately is the success for any intraocular lens, and especially the trifocal intraocular lens. Thank you very much.
Thank you. Partha, how many lenses have you implanted? So this is the only lens, or when did you start implanting these lenses?
12 days ago, sir.
So the other thing is that I have been implanting CT Lucia also.
Yeah.
I have found that the cartridge is very, the cartridge, when you try to force the lens,
Yeah.
It is very tight.
It is tight, sir. That's exactly what I said.
And sometimes some of my colleagues feel that the lens might get, there might be a breakage in the optic or at the optic haptic junction. So there's a fear, because it becomes very, very tight. And does it happen with this lens also?
Yes, sir. Absolutely the same. So, but the tightness does not mean that it will break, because the
I know, but that fear is always there, because when you are about to inject it, the force that you have to apply becomes much more than normal.
Yes. So that's a little bit of the learning curve, I would say, sir. And that is where, when you can lose contact between the tissue and the cartridge. And if you're implanting under hydro, then once you lose the contact, it might come out, and then you'll have to reload it, and then it becomes a very manual, and the preloaded aspect is gone. So CT Lucia, it's the same platform, sir.
Preloaded means this lens was loaded, and you just had to add the viscoelastic.
Yeah, just the visco, clip the flanges, and then just push, sir.
It's like the like the Lucia.
Yes. That is again another.
That is one of the negative points of CT Lucia.
Why does Zeiss have all female names given to its IOL?
Yeah, Lucia, Lala, and yeah.
Is it? This is a hydrophobic lens, isn't it?
I think all these thoughts come from our friend here.
Anurag.